I would like to thank Ovarian Cancer Australia for inviting me to speak about the very topic about research and clinical trials in ovarian cancer. But following that, I would also like to acknowledge all of you who come to this session today. It is actually quite overwhelming to actually know that you have ovarian cancer, let alone come to a forum like this where we have to speak about it and be proactive about it. Especially also the gentlemen in the room, because we love the support and we need support, especially when women are going through cancers. Okay, now, I am a medical oncologist, just like Michelle, and following Michelle's talk, I will be specifically talking about clinical trials and research, which is what I'm very interested in. I worked at the Royal Hospital for Women and Prince of Wales Hospital, as well as Chris O'Brien Lifehouse. I'm also an active research fellow at the NHMRC Clinical Trials Center, and also the ANSGAR group, which is the peak gynecological research group for Australia and New Zealand. I must say, though, there is a lot of research happening in ovarian cancer, and I may not be able to do it justice by talking about it with only 30 minutes to spare. So I hope what you can get away from this talk is that there is a lot of research going on and know how to access information, because information is power, and also perhaps simply speak to your oncologist to find out more details. It is very important to understand why we do what we do. So I thought it is important to start with a few pertinent facts. Actually, Michelle has already touched on that, but I like to kind of start it off with a few more reminders, because this is also a very important reality. So every day in Australia, 4 women will be diagnosed with ovarian cancer. The same day, unfortunately, 3 women will succumb to their disease. If we look at the numbers worldwide, actually I may be able to use this instead. Yeah, if we look at the numbers worldwide, 250,000 women will be diagnosed with ovarian cancer each year. Okay, maybe I can't use this. I'll use this. So, high-grade serous ovarian cancer is the most common subtype and also the most lethal of all gynecological cancers. And unfortunately, almost 70% of women are diagnosed when their disease are already advanced in their stages. So, in other words, stage 3 or stage 4 diseases. This is a figure that I created to describe the ovarian cancer disease trajectory. And I put different treatment schedules that is proposed along the way. Despite completing optimal first-line treatment, which often includes debulking surgery and chemotherapy, up to 80% of women will unfortunately experience disease relapse at some point. And with each episode of disease recurrence, we are seeing emergence of resistance and also increased numbers of treatment failure. And when we look at this, less than 50% of women will survive beyond 5 years. This is why we do what we do. We need more clinical trials. We need to understand the biology of ovarian cancer, and so that we can learn better to how to treat this to improve patient outcome. Through research, we have made incremental advances in ovarian cancer over the last 2 decades by anchoring questions around how to improve patient outcomes, not just their survival, but also the cancer symptoms and also the quality of life. And also, what we learned from all this study is also how to minimize the treatment side effects. In fact, nearly all cancer drugs that we use today were tested through clinical trials and with better cancer treatment depends on clinical trials on new drugs. The clinical trials help to determine whether the new drugs are safe and effective and suitable to be rolled on to clinical practice. And once we learn more about the studies and results from clinical studies, obviously, usually more questions come about, and often that's why we need to continue the motivations to learn and improve as time goes by. Research is really a team effort, and I would like to take this opportunity to acknowledge the whole team that has been involved and worked tirelessly to bring each clinical trial into life. We are not alone in this community. We have strong ties with organizations and collaborations in Asia, Europe, United States, and Canada. Most importantly, the driving force of all this is really our patients. And they too now become part of our team to keep us on our toes and also giving us the motivation to keep on the search for better treatments and solutions. Like what Michelle had touched on earlier, ovarian cancer is really many disease. It is important to understand that ovarian cancer is really a general term for a series of molecularly and etiologically distinct diseases that simply share the same anatomical location. So, let's see. So, for example, most invasive mucinous ovarian cancer are really metastases from a gastrointestinal tract origin, and that includes the colon, the appendix, and the stomach. Endometrioid and clear cell ovarian cancer are actually derived from endometriosis, which in turn is associated with retrograde menstruation from the endometrium. The high-grade serous ovarian cancer are derived from the fallopian tube or the ovaries, and which in turn, therefore, there's always this generalized term of ovarian cancer, but it really includes cancer of the ovaries, fallopian tube, and peritoneum. The mainstay of treatment when in ovarian cancer at the moment, unfortunately, is really lumping all of them quite together. But certainly, with improving precision of diagnosis and treatment, we are seeing more and more variations in treatment that can be tailored to individual histology. Like I said earlier, so currently these tumors are all treated quite the same with surgery and platinum-based chemotherapy. Some patients may go on to have maintenance bevacizumab or maintenance treatment, and subsequent down the track in terms of treatment for recurrence disease, the mainstay of treatment is chemotherapy. And the decision of which type of chemotherapy and which combination depends on the time from the last dose of chemotherapy previously, whether it's more or less than 6 months. However, as I mentioned before, these are really many diseases, and we learned more and more about different types of the disease. And from the genomic profiling, we understand that different subtypes carry different genomic profiling mutations that perhaps can be targetable with targeted agents, with new drugs coming through the pipeline. And therefore, perhaps we now have slightly more knowledge and also information to guide us how we should tailor treatment, because some of these chemotherapy may not benefit certain subtypes of ovarian cancer, such as the low-grade serous ovarian cancer, such as the mucinous ovarian cancer. And really, this is how we continue to learn as part of the way, and that's why we need clinical trials to inform us better, because this is the only way that we can systematically understand the disease and also find out who benefits most from the treatment. So the data collected through clinical trials can help us in many ways. We were able to identify risk markers, such as the finding of BRCA mutation in ovarian cancer patients, and how we perform secondary testing on their relatives to help them make decisions on cancer prevention. And I'm sure Dr. Leslie Andrews will elaborate on this in the afternoon session. Next, we also gain information about prognosis and also predictive markers to help us understand which group of patients would benefit most from this treatment. How can we avoid side effects of treatment if this actually doesn't benefit them? And how we can intensify adjuvant treatment if we know that perhaps these patients and with these particular subtypes can benefit from chemotherapy. And moving on from that, we also find out which combination of treatment is perhaps least toxic, but able to give us the same effective outcome that we all look for. This might be quite a complicated slide, but what I'm trying to go through here is to give you a taste of what the hallmarks of cancer comprises when it comes to their capabilities that they acquired during its transformation into cancer. They acquire different abilities, such as ability to evade growth, sustaining proliferation, which means that they continue to grow without anything within our body to stop them. They also enable capacities to resist cell death. And because of the whole way that they were able to evade through our immune system and things like that, they were able to continue to replicate into immortality. And by doing so, they also kind of draw blood supply, we call it angiogenesis, to actually allow them to actually move and spread to other organs. Over the last 2 decades of research and work in translational research, we actually start to see a few or a plethora of different targeted agents or new drugs coming through the pipeline that may target specific areas of the cancer biology and therefore render them effective. However, these cannot be actually applied to all cancers. It has to be applied specifically to different types of cancer who we all know by now has carried different biology, different types of capabilities, and therefore, although we have a plethora of drug agents, they have to be tested, for example, in ovarian cancer, to make sure that they actually work. So I thought I will take an example of PARP inhibitors and use that as the way of us understanding more about ovarian cancer. The Cancer Genome Atlas has informed us that about half of ovarian cancer actually has the vulnerabilities in the homologous recombination gene pathway. This is a pathway that is responsible for DNA damage repair. And of those, 15% are in women who carry a germline BRCA1 or 2 mutation. However, we do know that the similar vulnerabilities in homologous recombination deficiency is not just solely on patients with germline BRCA mutation. The tumor may carry the similar vulnerabilities, as well as other mutations that contribute to the same pathway. So I thought I have this slide to actually explain a little bit more how PARP inhibitors actually work in cancer. So I use the table analogy. So for example, we know a table has 4 legs. And because of the 4 legs, the table stands. A patient who carries germline BRCA mutation is like as if the table has lost 1 leg. There's 3 legs left behind. The table still stands, and therefore it's still functional. However, if we attack with PARP inhibitor, which means we take off another leg of the table, there's only 2 legs left for the table. The table will collapse and fall. So that's actually how PARP inhibitor works exquisitely or much better in patients with BRCA mutation, because we actually able to achieve a phenomena called synthetic lethality to actually achieve tumor cell death. For example, if someone doesn't carry the germline BRCA mutation, the table still have 4 legs. Giving PARP inhibitor will only target 1 of the legs. There's still 3 legs left on the table. The table still stands, and therefore it doesn't really do much. Again, this is a very simplistic way of explaining why PARP inhibitor works so much better in BRCA mutation carriers or tumors that carries the vulnerability called homologous recombination deficiency. But in reality, it's much complicated than that, and therefore we continue to strike in clinical trials and research how to tackle this and how to make better. So I thought I'll put out some evidence with PARP inhibitors that we had so far. We know about olaparib. However, there's actually other agents that carries the same class action called niraparib and rucaparib. And we know that PARP inhibitors is active in patients with ovarian cancer over the trials starting from 10 years ago, and now we see the medication is now available in clinical practice for patients who carry germline BRCA mutation. Again, these are work, what we see today is really work that has accumulated over the last decade. In the next 5 years, in the next 10 years, things might change, and we might learn more, and perhaps PARP inhibitors may not be just available to patients with BRCA mutations alone. However, we still need to work harder to actually find out the solutions and how we can better tailor the treatment so that it's effective and safe for our patients. So Michelle mentioned about the PBS approval. And yes, currently the PBS approved olaparib solely in maintenance treatment for women who carry germline BRCA mutation, who unfortunately have gone through a relapse of ovarian cancer and completed chemotherapy. We also now have compassionate access to olaparib for women undergoing first-line treatment who carries BRCA mutation. So we know that the FDA actually has also approved niraparib and rucaparib, but this only applies to patients in the United States. For niraparib and rucaparib in maintenance setting for patients with relapsed ovarian cancer, and also as monotherapy for women who has multiple relapse of cancer recurrence. There's a lot of clinical trials continuing. And certainly, like I said before, things may change in the next couple of years. Now that we talk about maintenance treatment, women will be having treatment for a long time. And certainly with chemotherapy and clinical trials, we are seeing more and more agents coming through the pipeline. There's not just the survival outcome that we are focusing on. We also want to know that the cancer treatments are actually tolerable and women are able to live their life whilst living with cancer. So a lot of focus comes to other important topics such as what is the toxicity? How can we support women to live better? And also, is it convenient? Is the oral tablet convenient rather than having to go through chemotherapy every 3 weeks with an IV infusion? Yeah, I thought it was just me. So, that's why you will also see that if you are one of the patients who participated in the clinical trials before, you find that there's more and more paperwork that we expect or request or ask of our patients. You find that majority of time you're filling questionnaires asking you about what your symptoms are and how you're feeling, and this will be asked multiple times at the beginning, every 3 weeks, every 3 months, 1 year later, 2 years later. We just never get sick of asking questions. But this is actually really important. Again, like I said, what we know now is the collective knowledge and information that comes through clinical trials and research through the last decade or two. But what we find more and more important is that patients carry a voice. We need to understand from the patient's perspective what they are going through. The side effects that we talk about when it comes to chemotherapy, the nausea, the fatigue, the insomnia, these are all information coming from the patients. However, in the past, studies has been performed by doctors documenting it, not by what the patient's actually going through. So patient-reported outcome, giving patients the voice to actually talk about and actually raise concerns about their treatment side effects and treatment concerns is actually really important. And I'm glad to actually say that Australia is actually the leading champion when it comes to advocacy for patients, because Prof. Michael Freelander actually initiated the study called Symptom Benefit Study that looked at this very topic. And through this study, over the last 5 to 10 years, we have established a patient-reported outcome measure tool that is specific coming from what the patients described and specifically for patients with ovarian cancer. And this is now rolling into a clinical study where we try to implement it to routine clinical practice. Oh, right. Glad that we are indoors. So, again, I thought what is more important in this forum is that I actually give you a flavor and an overview of what's happening outside in the whole cancer world. We often, every year, medical oncologists, surgical oncologists, radiation oncologists, clinical trials coordinators, like I said, the whole team would actually attend a yearly conference at Chicago called the ASCO 2019 annual meeting. It's a conference that's attended by 40,000 people, all working in cancer. And we discuss research and clinical trials updates about what's coming and what's evolving, what everyone else is doing. We are not alone in this little community. We have volume when it comes to rare cancers. We need volume, and therefore through collaborations, we know what's happening around the world and how we can continue to strive for improvement. So this is just really a little cherry picks of the abstracts that has been presented for ovarian cancer perspective. And you'll find that there are researchers going through in different settings of patients with ovarian cancer, whether it's first line, before first line, or at the time that cancer recurs. The nutshell is that there are research being reported about ways to expand PARP inhibitor beyond patients with BRCA mutation. There are also ways to tackle resistance to therapy, such as platinum resistance or treatment resistance. And there's new drug coming out from the horizon as a result, such as adavosertib, mirvetuximab. Again, these are all still experimenting through the clinical trials phase. However, certainly there are new potential treatments that might become available in the near future. And I thought I'll use the next few slides to talk about mythbusters. When I talk about clinical trials with my patients, a lot of them actually have a few concerns about participating on a clinical trial, particularly when it comes to whether a clinical trial is really experiments on patients and patients are all guinea pigs. The thing is, when it comes to the word trial, it is very confusing because it makes you wonder whether the treatment success is really up to a flip of a coin. And in fact, clinical trials nowadays are designed very carefully to address questions, and it's only the ones that would make a difference to the patients that can be selected and actually run and conducted. There's also a lot of strict regulations and monitoring process every step of the way to ensure that patients are safe, and as they are continuing participating on a clinical trial, there is a benefit derived from it. So this is why there's a lot of close follow-up requirements and also many hospital visits when someone is actually participating in a clinical trial. It's really to ensure safety, but also this is also an element that is important for patients to consider when they participate in the clinical trial, because it actually takes quite a lot of their time and effort, and certainly blood tests when it comes to biological translational studies. And the risk of severe side effects or even dying as a result of a clinical trial drug is very small, and certainly there will be every effort in that way to actually make sure that this is prevented as much as possible. If a clinical trial in any step of the way was found to be detrimental to patients, they actually will be shut down. So a clinical trial that is run is actually being monitored very vigorously to make sure that we are doing the best for the patients, and also we are still able to answer questions that is relevant and important for our patients. It's also a way to access leading-edge treatment. Really, working at Prince of Wales, I do have the fortunate position to look after a few patients who are actually the forefronts. They received PARP inhibitor as part of a clinical trial study 10 years ago, and they are the few that actually have exceptional response to the treatment and therefore are still around with us today. And certainly, participating in a clinical trial actually give you access to new drugs in the pipeline, but certainly this has to be run in a regulated and very systematic fashion so that we make sure this is safe. Second myth, clinical trials means that patients can be on placebo, and which means I'm not on any treatment. It's actually quite rare nowadays for a patient participating on a clinical trial to be not on any treatment. And to help you understand that, I actually want to talk about the different phases of clinical trials, because that's also important. Clinical trial comes in many phases, starting from preclinical, progressing to phase 1, 2, 3, and after phase 3, it's likely that this trial will be deemed positive and effective to patients and will be rolled out to routine use, and that's where phase 4 happens. When it comes to the early trials, such as phase 1 and phase 2, majority and actually all patients are on the active drug, new drugs, because the drugs at this stage of the clinical trial is being tested in incremental dose to find the right dose and also to understand their safety profile, such as their side effects. And once that's established, we move on to what we call a phase 3 study, where we compare the new drugs to best standard of care. And the best standard of care at this stage is what we use in routine clinical practice. That can be chemotherapy, or that can be, in some very rare situations, no treatment. And this is where we have the concerns about patients being on no treatment. However, no treatment options, it's actually really because they have exhausted all treatments, and therefore at routine practice point of view, that's why some patients is not on any treatment. Again, these are rare situations, and certainly as you are approached for a clinical trial, your oncologist will actually be able to explain how that applies to you and how the clinical trial will be able to show and what is required and for the duration of the clinical trial as you participate on. What are the current clinical trials for ovarian cancer that we have in the horizon in Australia or in Sydney? We have clinical trials that look at specifically how the drugs affect the patients and whether this new treatment is actually effective. But certainly there's not just a drug trial. There is tissue molecular profiling study, which mainly looks at how to help us better understand ovarian cancer, and also how we can actually understand rare disease, such as different subtypes. So Professor Anna DeFazio from Westmead actually is the champion lead of this study called Innovate. This is actually available for all women with ovarian cancer, no matter what subtypes, such as clear cell, mucinous, high-grade serous, and this actually help us better understand different types of disease and their genomic profiling differences, and therefore perhaps in the near future, when a new drug comes into the pipeline that can target certain mutations, therefore then we can actually design a study or make the drug available to the patient in a clinical trial. There's also the Australian-wide study called the AOX, Australian Ovarian Cancer Study, which is also a study that looks at tissue and clinical data so that we can contribute to the better understanding of ovarian cancer itself. Currently, there is a plethora of clinical trials available, and again, they are in slightly different setting and different situations. Certainly, not every trial will be suitable to one patient, and we have to always consider if this is something that is important and suitable for you. But I just want to kind of give you a flavor of different studies that's available around in Sydney. And certainly if you have any questions about whether I can participate on a clinical trial, speak to your oncologist and they will be able to give you more information. Some of these studies are looking at combination of immunotherapy with chemotherapy. Some of these studies are looking at maintenance treatment with PARP inhibitor and immunotherapy. And some are actually specific to clear cell ovarian cancer. And certainly others kind of combinations such as PARP inhibitor with an anti-angiogenic agent, which is a different agent. But these are all studies that we are looking at how to circumvent the activity of PARP inhibitor beyond just being active in patients who carry the BRCA mutation genes. these are a few resources that you can find if you would like more information, and certainly these are the websites that I would actually send all my patients to if they want to find more information. And to access information through these websites, they are often free. What you need to do is register. For example, LVQ, you just need to register, and it gives you a login, and then you can access patient information and also your treatment information as well. So in summary, there are a lot of clinically meaningful discoveries in ovarian cancer over the last 2 decades. A majority of them starts with clinical trials. Certainly, in Australia, we are very productive and active, contributing to research and clinical trials activities. And participating in clinical trials has advantages, but certainly we are monitoring each of the trials very carefully to ensure safety and also whether this is actually beneficial to our patients. Know how to access information is really the key, and I encourage all of you to discuss and speak about it with your oncologist to see if that is something that suits you and something that perhaps not now, but something you can consider in the near future as well.